and welcome to the second installment of the SEIU-UHW Facebook live stream to bring all UHW members and many of our colleagues and friends and coworkers and family members up to speed on the best information that we have regarding this pandemic, developments that have taken place over the last week, and some of the issues that we're trying to troubleshoot and deal with as we go forward. My name is Dave Regan. I'm the president of SEIU-UHW. And before I introduce or ask the guests to begin introducing themselves, I just want to review some of the reasons why we made the commitment beginning last week to do one of these Facebook Live events each Wednesday evening at 7 p.m. For as long as we're confronting this pandemic and all of the, really unbelievable challenges that come with it. First and foremost, we want our organization, our union, to be a place where our members can come together and get good information. There's so much confusion, there's so much information, there's so much of everything that a lot of times we all feel as if we're experiencing sensory overload. And so we want this to be a place that people can count on and rely on every week, where you can check in and you can get some up-to-date information. You have an opportunity to interact with rank and file member leaders of ours, as well as experts in the infectious disease community and the epidemiological community. The second thing we want to do is we really want this in some sense to be a public service. And unlike these type of Facebook events we've done in the past, this is one that we're opening up to anybody. And frankly, what we experienced last week was, by a factor of 4, we had more viewers in the course of the last 7 days watch what we did last week. And we think there's a real audience for this, and we want to step into that space and do the very best we can to create a venue where people can come together and help each other navigate all of these really difficult issues. And finally, we understand as a healthcare workers organization that this is a completely unprecedented event that we're all now just at the beginning of living through. I think it's fair to say that this, if it already is not, it certainly will be the largest public health crisis that we've faced in our country, in our country's history. This is something, as you can tell by watching the news, is affecting, not just every state and every community in the United States, but countries and people around the world. And so it's just impossible to overstate how important this is. And for those reasons, we wanted to figure out how we could play a constructive role. So tonight I'm joined by 3 SEIU-UHW rank and file member leader guests. I'm going to ask the 3 of them, beginning with Donna, to introduce themselves, and then I'll take a moment to introduce the special guest that we have after we hear from our members. So,
okay.
Well, let's begin with Donna.
So good evening, everyone. My name is Donna Norton. I am okay.
There you go, Donna.
Okay, all right. So it came up all over my screen. It says you're muted. Good evening, everyone. My name is Donna Norton. I am an LVN by trade. I have been an LVN since 1975. So I have a lot of history in the healthcare. And I work at Kaiser Vacaville as a UHW member. And I look forward to participating in this tonight and being of whatever help that I can be. So good evening, everybody.
Great, thank you, Donna. Now I'd like to turn to Gisela. And Gisela, you have to unmute yourself also.
Can you hear me?
Yes, we can hear you.
Okay.
You might want to just lean back a little, Gisela. There, okay. Perfect. There you go.
Well, I cannot see anybody, but my name is Gisela Thomas. I'm a respiratory therapist. I work at the Desert Regional Medical Center in Palm Springs, and I'm happy to be here.
And how long have you been a respiratory therapist, Gisela?
I don't really want to tell because I probably more than I succumb your age. Let's put it this way.
Okay,
It's
a
been a long
considerable
time.
amount of time.
Yes, quite some time.
Okay, thank you. And the third member we have tonight is Jessica. So Jessica?
Hi, my name is Jessica Rodriguez. I work at Kaiser Oakland Emergency Department as an emergency room technician. I've been at Kaiser for 19 years, 20 years this year, and I'm happy to try to help as much as I can. I'm also part of the executive board. I'm an executive committee member, and this is going to be my second trip.
Great. Thank you very much, Jessica. And before I ask our next group or our next guest, excuse me, to say a little about himself, I just have the pleasure and the honor to give a brief introduction for Dr. Stephen Lockhart. Dr. Lockhart is the Chief Medical Officer for the Sutter Health System here in California. He's a resident of Northern California, lives in the Bay Area, and like all of the rest of us in the Bay Area is coping with the shelter-in-place order that got implemented this week. He also is both a medical doctor and he has a doctorate in biostatistics and has done a lot of work and is trained in epidemiology as well. So again, from the perspective of wanting to make sure that we have access to, the top experts in the field and folks who can really share, a rigorous scientific perspective with us, we're really pleased that Dr. Lockhart has taken the time to join us here tonight. And we've asked him to begin in the period he has with us here this evening. After he says whatever he'd like by way of introduction, to really spend about 10 minutes talking about the physiology of the disease, what we've learned in the last week, and what we can expect going forward. So with that, again, welcome to SEIU-UHW, and thank you for joining us, Dr. Lockhart.
Thank you very much, Dave. I'm Steve Lockhart, as Dave has mentioned. I'm a physician and also a PhD statistician. And the first thing I'd like to do is to thank you for the opportunity to speak with all of you. It's actually an honor and a privilege. I'm obviously in a administrative role at the moment, just for more than 25 years, which means that I've worked with a lot of SEIU members and know the dedication that you bring to our patient care every day. And also I'd like to thank the union membership, take the time to do that, because I think this is one of the truly most valuable aspects that the union can provide, is this type of forum to communicate with members, and also for us to hear from members as well, to learn what's really happening on the ground and what the concerns are. I'm going to give just a little bit of an update here. I will readily admit that I'm going to tell you what we know, but there's also a lot that we don't know. It's a rapidly changing situation. So it is very likely that for some of your questions, the most honest answer I can give you is I don't know. And that could be a combination of it's not known, or simply it is known and I just don't know, because that information hasn't yet been disseminated. So let me start with a little bit about the novel coronavirus. It's novel because we've seen coronavirus before. We've seen SARS back in 2003 and MERS in 2012. SARS was a virus that had about a 9.6% mortality rate. I think there were about 8,900 cases worldwide in about 25 to 30 countries. And then, of course, in 2012, we saw MERS, which was much smaller, about 2,500 cases with a 37% mortality rate, mostly centered in Saudi Arabia. But by contrast, the novel coronavirus, what we're calling COVID-19, we're currently seeing, I'm looking at the numbers now, 216,000 basically cases worldwide. So the magnitude of the spread is far greater. The mortality rate seems to be around 2%, 2 to 3%. Of course, some of that depends upon the fact that we don't, in some areas we have a lot of testing, in other areas of the world we don't. Those numbers are sort of what I would call current death rate, but it's a big deal. And of course, we started with the idea of containment. When it started in China, everyone was hoping that we could limit it to China by restricting travel and other interventions like that. And now we're in a mitigation phase. For any of you who've seen a recent map, it's red all over. In fact, obviously places like Italy, I think has 35,000, almost 36,000 cases. And in the US, we're now over 7,700 cases, something like that. Something happened. Can you still hear me?
We can hear you, Dr. Lockhart.
Great. All right, I think my computer just went to sleep, so I have no idea.
Okay, no, we can see you fine and hear you fine.
Okay, good. So basically, it's red all over. So now we're in the mitigation phase, and the growth rate in the United States it's doubling about every 5 days. So what this really brings, our concern is our ability or capacity of our healthcare system to manage all of this. And I think one of the most critical pieces is how many critical care beds ultimately we're going to need. And there's a lot of models that look at these sort of things, but it's pretty clear that with that kind of doubling rate, if it goes unchecked, that we will very rapidly exceed our ability to take care of the most critical patients who will need Gisela's expertise in terms of mechanical ventilation and intensive care support. So one of the strategies for mitigating that, and which we're all doing right now actually, is a lot of these social interventions. Since there's no vaccine, we really have to rely on things like trying to contain where we can hotspots, but also closing of schools and universities and social isolation, sheltering in place at home. And the more severe we do those, the earlier them to flatten the curve. So if you think of the peak of incidence, the more we flatten. And if you look, for example, at the number of ICU beds per 100,000, some recent studies, there's one out of Imperial College London that was the one, but it was a study that also looked at Great Britain and the US. Unchecked, we'd have about 275 per 100,000 with all these mitigation strategies together over a period of actually, I think when they studied it was like 3 months of doing this, not just a couple of weeks. We had the opportunity to bring that down to maybe 100 per 100,000, but you can still see that that's a lot of folks. When I look just at our Sutter Health numbers, we have about 3.5 million patients that we care for in Northern California. That's somewhere, even if we get it down to below 100, it's somewhere around 1,500 to 2,000 patients requiring ICU care. So whatever we can do to blunt that and move it out is obviously important. So what are we doing in terms of strategies to protect our healthcare workers, ourselves as healthcare workers, and our other patients in our community? I think the biggest thing, strategies we have at our disposal as provider organizations, is to try to keep patients who potentially have the disease out of our waiting rooms and out of our hospitals and if they don't need to be there. Obviously, sick people need to go to the hospital, but if you're only mildly ill, but obviously contagious, we want you to not take that method. So I know we have been, and I'm sure Kaiser, Dignity, others are doing much of the same thing. I mean, these are strategies that we're all employing, with things like nurse advice lines, call first before you come in, video visits. If you do need to get a test, come in and have it done in your car. So all these types of strategies to keep people out. Now, if patients come into the hospital, obviously we need to care for them, and that's where we think about things like PPE, or the personal protective equipment, which, as I'm sure you all know, is in very short supply around the country. And we are at various times are sort of nicking into the either the state or the national reserve emergency supplies, but even there's not a whole lot of excess. So as we look towards what those protective gear recommendations should be, we're trying to balance sort of the shortage of PPE with what we know about the the disease itself. So if we think about the way in which the disease behaves from an epidemiologic perspective, it appears like it's behaving very much like a droplet precaution type of disease as opposed to aerosol. Although the CDC guidelines still recommend, for example, for any kind of procedure like a bronchoscopy where there's a risk of aerosolization, that should be done in negative per room, and that should be done with the full N95 mask, and of course the contact precautions of a gown and gloves. In other circumstances, if N95s are not available, and realistically they are not very available these days, one can go with a surgical mask with a face shield and contact precautions of gowns and gloves. Interestingly enough, that's where the WHO, the World Health Organization, is on this as well. And if we look at Canada, they actually early on went to regular masks with droplet precautions. And I mentioned Canada only because they had outbreaks of SARS and it dealt with that before. So it feels like that's the proper place to be as far as our protective gear recommendations. But again, those have changed, from last week before, and they could potentially change again. But that feels sort of like where we should be right now. I should mention that with 95s, of course, we have to remember that we have other patients for whom N95 masks are really essential, like our TB patients or our disseminated herpes patients and so forth. So if we have shortages for the caregivers who need to take care of those patients, we could have a really big problem. The other piece that's obviously playing a role here is testing, both in terms of us understanding how many patients we actually have. And right now, testing is not as available as it should be. And also the time of testing has actually, unfortunately, increased a bit. As we've started testing more people, it's gone from 2 to 3 days to about 6 days. And the implication that has on PPE is that, of course, the more quickly, most of the patients we test obviously are not positive, but we are testing them and then we're treating them as if they're positive until the test comes back. So we'd save a whole lot of PPE if we can get those test results back a little earlier. So we're hoping within the next few days, some of our shared labs at our facilities, I know it's at Sutter, probably at Kaiser as well, and other places, we'll have the proper reagents and materials to do more tests. And those tests, if they're done in your own lab, should typically be turned around in a day. So that should help quite a bit. I think that's probably most of the things that I wanted to cover initially. I know there's probably a bunch of questions and other issues will come up, so maybe I'll stop there. And
perfect. So Dr. Lockhart, we're going to turn to the questions and the moderator will let us know what's coming in. But just to summarize, and one of the things we want to do on each installment of this is make sure we're sharing the best science with everybody who's watching this and trying to understand. So I'll try to summarize what I took from your comments, and I'd just like to give you an opportunity, make sure that if I didn't say it correctly, that you can correct me. So the first thing, again, the best science tells us that this is a disease that is transmitted through droplets. We are now pursuing a mitigation strategy. Anybody who is doing a procedure where the virus could aerosolize is advised, according to all the best guidance, to use the N95 masks and the highest level of PPE. But on the question, and there's been a lot of commentary from our members about, is this disease transmitted via airborne means? I believe the answer to that is no. So I just want to give you an opportunity to react or respond to any of that, and then we'll ask the moderator to go to questions.
Thanks, Dave. I would say that given what we know right now, particularly how the virus behaves in vivo, I would say that that's correct. Our best thinking is that it really behaves more like a droplet than it does the aerosolized, which is not to say, obviously, if you're 6 inches want to cough on you, obviously that's going to be an aerosolization type of situation. But as far as how we think about room cleanings and that sort of thing, how we manage our patients, the droplet precautions seem to be the most appropriate.
Great, thank you. So moderator, could we turn to questions from the viewers?
Yeah, so we have a question, looks like combined from several people, Christina, Joe, and Deanne, who ask, how much worse is this virus than the flu, and how long does it take for the symptoms to show up?
Okay, so the flu, that's an interesting question. The flu actually winds up killing more people because it is more prevalent. The mortality rate is about 0.1% with the flu, as compared to what we think is maybe 2 to 3% with this. But of course, the flu gets a lot of people. Now, of course, with the flu, we have vaccines. They're not percent effective because we make them against the strain, the most common strains that we have at the time. And the other part of the question, I'm sorry, there was a question about the flu versus this, but there was another part, and I apologize.
Yeah. So the other part is, how long does it take for symptoms to show up?
So probably symptoms within 5 to 7 days. I was actually just on a call today with Dan Varga, who's out east at in New York, where they've had, I'm blanking on the name of the system, but they have some of the greatest concentration of cases. And they're actually sending people back to work after 7 days if they're asymptomatic, because the data that they're looking at says that most symptoms show up by 5 to 7 days. The classic sort of thinking is anywhere from 2 to 14 days. But I think a lot of folks now are thinking that if you've had minimal to moderate exposure and you're asymptomatic, that you're basically fine, but you should monitor. And if you've had a high level exposure, now some people are saying even within 7 days, if you've had no symptoms, you're probably fine. So.
Thank you. Moderator, I'm sure we have more.
Yeah. And then there's just a general question about what exactly is usually included in the treatment for COVID-19?
Well, at the moment, supportive care, there are some drugs that are being looked at. As far as I know, they're all experimental on protocols as far as this indication. There was also something out of Belgium which had tried, believe it or not, chloroquine, but fairly high dose chloroquine for people who were ventilated and on respirators. So I think the question, I think that answer is one of those, I don't know what we would ultimately do if we had a big crisis in terms of what some of those therapeutic interventions might be in terms of antivirals. But it's not like, the flu, we have Tamiflu that we can give. There's no one agreed upon regimen right now.
Just next question, moderator.
Okay, we have another question from Sulema, asked if the incubation period is up to 14 days, can we assume that person is negative for the virus after that period lapses?
That's a good question. The true answer is it's a reasonable assumption to make that after 14 days of being, I assume you're saying if someone's been asymptomatic for 14 days, that they should no longer be shedding virus. But I honestly don't know the statistics in terms of the curve, whether I'm sure that that's not true for everybody. But I imagine that it's highly likely that, obviously with these things, you go with the 95% probabilities. So that is a good cutoff to use. I don't think anyone would go beyond that, but.
Okay. We have some other questions here. Linda and Judy both raise a question about older healthcare workers. Also, there's a governor's order for self-isolation for people over 65. What is the guidance for healthcare workers who then find themselves over 65 or have other health issues?
Well, that's, I don't know that we have a totally agreed upon answer to that as a system of healthcare providers. And I think that's something we're struggling with right now because, of course, there's a fairly significant part of our workforce across the board, you know, who are in healthcare, be it physicians, RNs, LNs, techs, therapists, everybody who is older than 65. So if we sort of said everybody who's over 65 should stay away from work, we would not be able to provide the care that we need to provide. On the other hand, sorry, I just went dark again. I know we do not have specific policies that suggest that people should do anything different, but of course we know that there's increased risks. So that's one of those answers where I sound like I'm hedging because I think I really am. We haven't really fully addressed that in a meaningful way.
If I might, I agree with what Dr. Lockhart said, and as was properly referenced in the question yesterday in one of the governor's executive orders, that directive and that guidance was in fact given that for people over 65 that they should, you know, isolate themselves and they should refrain from a variety of activities. And then a little later on it says, however, this doesn't apply directly to the healthcare workforce. And frankly, as a general rule, we both need to take extra precautions for people over 65. And as a general rule, we also need every capable and asymptomatic healthcare worker to fight just the magnitude of this incredible challenge. I think for our members going forward, you know, I don't think there's a black and white answer. And obviously there are some healthcare workers over 65 who have a personal health history that would in fact indicate that they, you know, should take a level of precautions that may not be appropriate for, you know, somebody without that history. So I want to encourage our members that this is going to be an active conversation. It's something we're going to be working with people about. We'll be working with your employers. But those two things are both true at the same time. And I think that's why, you know, Dr. Lockhart, you know, says it's tough to answer that one way or another. And the final point before we take another question or two, before Dr. Lockhart has to leave us, is that there is no way to combat this as a public health crisis unless we keep the healthcare workforce as protected as we possibly can, able to do the work that they're trained for, and really just, you know, allowing to make the commitment and to deliver the care that we desperately need. So I just wanted to add that, but I'd like to ask the moderator I think we have about time for maybe two more questions for Dr. Lockhart, and then we're going to turn to our member leaders in the second half of the conversation.
Yeah, so we have a question from Shelby, who actually getting a question about COVID-19. How is this different than other coronaviruses?
Well, as I mentioned earlier, it is less deadly, but the what we call R0, so getting a little geeky here, but the R0 is the relative infectiousness of a virus is about 2.4, which means for every person who has this novel coronavirus, you're likely to infect about 2.4 people. And so that's greater than either of the other two coronaviruses, SARS or MERS, which means that essentially it's how quickly it spreads. The doubling rate is much quicker. So it had hit in 6 weeks, I think, if I'm recalling correctly, the numbers that it took SARS a year to reach. So it's moving very quickly, and that's one of the things that's making everyone so anxious right now. Is when I say a doubling rate of every 5 days in the U.S., that this is how Italy gets into trouble, because they're, you know, we're on the we may feel like we're to see it now, but it can, that curve can be so steep that, you know, a month from now we can be seeing go from tens of patients to hundreds. And
Great.
and of course, there's no vaccine or no direct treatments that we have for it right now.
Great. So moderator, let's take one more for Dr. Lockhart, and then we'll move to the next section. Moderator, you might be muted yourself.
I was, apologize for that. So our final question is really about testing. We've seen members who, healthcare workers, said they've been exposed to testing or have been exposed, but testing has not been available for them. How is it decided who gets the test? And if you could just speak to the general availability of the testing and the testing capacity that we now have both here in California and even more broadly, if you can.
Right. Okay. So the criteria for testing. So obviously, initially, these tests were all done by the CDC, and you had to go through CDPH, and it was all public health testing. And there wasn't a lot of it, and it took a very, very long time. Now we have a little bit more access to testing. Commercial labs are starting to do it, Quest and I think LabCorp, and then the FDA just a week ago. I mean, these things happen so quickly. It's like literally, I think 5 days ago or something, agreed that any CLIA certified lab could do the tests, develop their own laboratory derived tests without emergency use authorization. So they just had to let them know they were doing it and then provide validation data. As a result, a lot more labs are starting to do it, like our shared lab, and I'm sure, like I mentioned, you know, Kaiser and others, you know, have those capabilities. And the problem is the availability of the substrate and the swabs. I'm told that this week they will be more available, but you know, the numbers that we're hearing out of the administration, quite honestly, don't match with the reality on the ground. Let's put it that way. You know, so whereas we're hearing there will be millions of tests, it's a much slower ramp up than that, but there'll probably be, you know, thousands, which will be very helpful. As far as who we test, so I can only really reflect what we decided at Sutter Health, and you know, it was the best thinking we could bring to bear on this. So I don't know that it's right, but of course we're not going to, when the testing is limited, we're not going to be symptomatic. Or those who are, and so if we look at symptomatic patients, if they meet CDC criteria for, you know, the early on criteria of travel or exposure, et cetera, then they should be treated, but we try to get the government to do those tests. If not, we would do the test. And then you have, you know, moderately to severely symptomatic patients where we would do testing, and then we also stratify. So healthcare workers, school teachers, people who are going to be really in the public, connecting with the public on a large scale, that pops them up to a higher level. And of course, anybody for whom the test would determine or change the treatment. So essentially for us, if you're a healthcare worker and you've had an exposure that's anything other than minimal, if it's minimal exposure, we would have you self-monitor or maybe, you know, self-isolate monitor. But if it's, you know, if it's a significant exposure, we would clearly test those folks for a couple of reasons. One is obviously it's appropriate just according to the strata of how we think about it, and also we have to keep our staff safe. So that's how we think about it. Doesn't mean that every healthcare worker is going to be able to come in and get a test because they, you know, someone had COVID-19 and they were, you know, across the hall or far enough away, or they, you know, was masked and you know, didn't really have a significant exposure. But if you did have one, we definitely would test.
Okay. Well, Dr. Lockhart, again, on behalf of our entire organization, I really want to appreciate you for taking time to join us. It's really helpful. And I know our, both Sutter and UHW, we're going to continue doing everything we can to get on top of this and find a way through it. So thank you.
Well, thank you very much. I really appreciate the opportunity, and I appreciate the partnership. It really means a lot. So thank you.
Thanks. So now I'm going to turn to our member leaders, and let me try to set this up and what we're going to ask each of them in turn to do. And then again, we want to open it up for another round of questions. And so this is really the part of the conversation where, we want to be able to share our experience on the ground as healthcare providers on the front lines in different settings around the state, different employers, what have you. So first, we're going to ask Donna Norton, who's been doing a lot of work inside of Kaiser, to talk a little bit. Dr. Lockhart alluded to just the very real challenges that we're facing because of the magnitude of the numbers of people that have already, been affected, but certainly what's coming down the pike and the whole issue of supplies and PPE. And Donna's been a real leader. So in a moment, we'll ask her to do that. Then Gisela, who is in Southern California at a Tenet hospital, we'd like you to share, both as a respiratory therapist and what you're experiencing inside of Tenet, just what's developed in the last week and how you and your coworkers are handling it. And then we'll turn to Jessica Rodriguez, who's also been somebody representing all of us in UHW and conversations with Kaiser Permanente and trying to really, strategize around how do we combat the coronavirus. So we'll go first to Donna, we'll do each person in turn, and then we'll open it up for questions for all three of them. So Donna?
Hi, so I have had the honor of sitting at some pretty high-level regional meetings. We've been meeting twice a week to really talk about how do we get a handle on this as best we can. So I'd like to say that through that partnership, we have been able to be instrumental in getting some things done. This is a very, very scary time for all of us. And the best thing that we can do as leaders is try to remain calm and assume good intentions on both sides. This is something that we haven't been through before. So in addition to the regional meetings, each of the facilities should have a command center and some meetings that are going on between the labor, whether it be the rep or the field rep, and their command center, so that accurate information can be sent out. Now, I have had experiences where some inaccurate information or some liberties have been taken, or just the rumor mill is flying, and as best we can, we want to try and calm that down. So there's a lot of interest about personal protective equipment. And this just seems contrary to what we are so used to doing. So we are used to one patient, one PPE, and not having to be cognizant of how we're using it or not using it or taking it down a level. And so this whole thing seems contrary to what we're used to. But we must preserve the PPE for the people that need it. Because if we can do a combination of preserving the personal protective equipment and sheltering in place and social distancing and all of that, we can hopefully have enough for when we need it. If we don't do all of these things, then it is a very real that we won't have enough. So what I saw in my facility is that they did go around today, and the managers went around and they took the PPE out of the units, because we're trying to get a good handle now on how much we have and really put it in where it's controlled. So people should try not to hoard PPE, don't use it inappropriately. But at the same time, everyone should feel comfortable that they have the appropriate PPE for whatever they're going to be doing. It's definitely a balancing act in that way. And really, I think the doctor, he hit on everything else. It's a scary time. And rest assured that I think all of our hospitals, all of our leaders in the union, everybody is doing their very best right now to get through this. And I think if we can all just assume good intentions, remain calm, do what we're supposed to be doing, bring forward questions. I mean, the best source that we have is what is happening on the front line. So bring those things forward so that we can try and get concerns around them and try not to feed the rumor mill. That's the best advice I can give.
Thank you, Donna. And now let's hear from Gisela in Palm Springs.
Okay. Well, pretty much what Donna said, we experiencing that in our facility. The masks are pretty much kept under lock and key and given out when needed. We had a meeting with our HR department last week on Thursday, and we walked out of the meeting, and half an hour later, HR called me and said, "Oh, Gisela, there's a change." One of the changes was that anybody who had flu shot, they're not given a mask. But the only time you will get a mask is if you go to, enteric precaution, VRE, MRSA, and you get your regular surgical mask, and otherwise you will get your N95 when you go to treat a patient who is rule out COVID-19 or TB. Masks are in short supply. What I understand when I get calls from from the staff, some of them in the middle of the night, "Gisela, I haven't got a mask. I need a mask." We too treat droplet precaution. I was talking to one of our ER physicians who would like that all doctors use MDIs instead of aerosolizing anything, treatments, particularly in respiratory. But she mentioned that they get some resistance there. Hand washing, they constantly, harping and monitoring the staff, making sure that everybody washes their hand long enough and frequently enough throughout the shift. So our HR department was appreciative of the fact that we stepped up with UHW to talk to them about it. Also, they didn't really like it, but they did appreciate the fact that we did. Personally, I feel that we have so many different hospitals and everybody's doing something, and we should somehow get the best practices posted or because communication seems to be one of the biggest issues. Many times we have the huddles in the morning, but it sounds like not always do all of the information get to everybody, and that's frustrating to the staff, and that's and then just like Donna said, the rumor mill, it's almost like our own members undermining themselves with the rumor mill when they hear something. But
so if I could hop in, Gisela, and I just want to expand on a point you made, about getting good information. I just want to remind everybody watching that we're doing our very best to get the best scientific information on our website at www.SEIU-UHW.org, and also to keep people apprised of what's coming out of state government here in California in terms of the governor's executive orders, what kind of public health guidance we're experiencing, and everything else. And so to Gisela's point about just the importance of combating rumors and bringing good information, in addition to these sessions every week, we also want to make sure people are availing themselves of the website. So now I'd like to just turn to Jessica Rodriguez in Oakland and ask her to talk about her experience in the last week, and again, playing a leadership role in dealing with Kaiser on a statewide basis about how to combat this. So Jessica.
Hi, yes, thank you for the opportunity to be here. You guys know this is not my favorite thing to do, but these are different times and we have to play our part and do the best we can to really support everybody. And by everybody, I don't just mean our union members, ourselves, but our families and our communities. I've had the privilege, like Donna said, to sit at tables at the state level, local level, regional level, and facility level to try to really work out and go over the list that we developed of things that we expect from the employer on behalf of all UHW members. They have been receptive, but there's a lot of work that we need to do. As far as my experience in my own facility and the experience that my executive board has shared with me, it's been very difficult to really get all the information in a timely manner to all the departments. There's a lot of missing information. There's a lot of questions. The anxiety is real. I'm anxious myself, but the way that I find peace, the way that I find comfort is by really relying on those leaders that I have worked with for a long time already, relying on my family members, really taking care of my own department. I mean, the way they have stepped up, all the emergency room technicians, LVNs, receptionists, everybody that's part of our department has really stepped up. If I'm not there physically, because I'm in all these meetings, they really stay in communication. They put a group text message together where we educate each other, we advocate for each other. The other day, when was this? Yesterday, our contract specialist, Sonia Allen Smith, and myself were going to different meetings regarding this issue in the facility. And walking down the hallway, we ran into one of the huddles. Some of the messaging was missing. We chimed in a couple facts, 2-3 things that we mentioned. And within a few steps from there, people were reaching out to us, really hungry for information, really wanting us to come to their huddle. It started with like 2-3 people. We had 7 people. Then we ended up going through the whole imaging department on the ground floor at our facility. And when we started talking to them, their shoulders were like really tense. Their body language showed the anxiety. And again, by the end of our conversation, they were a little more calm. Their nerves were a little more relieved. I really would like to mainly make a call. You guys shared a lot of facts about COVID-19, all the different concerns, but I really want to call out to all the members, all the leaders, whether you're a contract specialist, a e-board member, if you're one of our informal leaders that have helped us in other campaigns and anything else, if you're the voice of the department, if somebody goes to you for advice all the time, I'm calling on you to please help us distribute this information, advocate for people, gather questions together, send them to the leaders in your department or your facility so we can address them in real time. There's a lot of things changing on a daily basis, but I know that we're going to get through this. And we pride ourselves saying that we are members of healthcare worker organization, right? We like to say that we're member driven. We like to say that we are strong, that we're stronger together. Like, this is the time to stand together. I'm sure we're going to get through it. I want to reassure everybody that we're working day and night on our days to work, on our days off, to make sure that everybody is really getting the best protection, that we're getting the most up-to-date things and holding the employer accountable. I can't say anything more than that. I'm calling on everybody to please stand up, reach out. Everybody in my constituency, I wish I could go to every single person and have a personal conversation and explain everything and share what I know, every piece of information, but I can't do it by myself. So I need your help. We need your help. Please reach out, and I know we're going to get through this.
Great. So thank you, Jessica and Donna and Gisela. And now, moderator, we'd like to open it up for questions for our member leaders.
Yeah, so we have a large volume of questions about childcare, especially now that schools are closed. So the question is, what is SEIU-UHW doing to help healthcare workers who are facing basically a childcare crisis because school daycare centers are closed?
So maybe I should take a shot at this, and then if any of the others would like to. So we're doing two major things, and then there's a third thing that I would ask for. First thing we're doing is we've been directly advocating with Governor Newsom and his administration that because we can only be successful in combating the COVID-19 pandemic if we have a protected and stable workforce at work, that healthcare workers, we need to make sure that there's special attention paid to how do we, manage our healthcare or our childcare situation. We've suggested a number of ideas, including, how do we provide stipends? Perhaps there's a way through tax credits, other sorts of financial support to help ease the burden of unexpected childcare. So that's one thing we're directly advocating, and the governor right now was granted really unprecedented authority yesterday by the legislature to be able to take initiative to deal with this. And the second thing that we're doing is we're engaging directly through the California Hospital Association and our employers about what can we do to set up childcare operations, in proximity to healthcare institutions, specifically hospitals. I know everybody understands this is a monumental logistical undertaking because we're both faced with these situations of social distancing and shelter in place. But at the same time, we're asking the governor to be flexible about the legal issues and the rulemaking and the guidance coming out of Sacramento. And we're also looking to see what can be done so that there's a safe, available, and serious and effective way for healthcare workers to be able to do childcare. The third thing I would say is that, there's anybody who has, a good idea or a good suggestion, please, let us know. If it's a local solution, we'll try to make sure we get that to the right public officials. So just to summarize, we're operating directly with the governor in terms of advocacy, directly with the industry and the governor in terms of trying to create capacity for childcare. And then the third thing, we want to be a facilitator and a conduit for good ideas that people might have anywhere in the state. And I don't know if the others would like to, it's a huge issue. We all recognize it's a huge issue for our members. Okay, so we'll take another question, moderator.
Yeah, so we also have many questions and concerns people are raising around inconsistency with regards to PPE. Some people being allowed to wear masks, people not being allowed to wear masks, even if they bring them from home. And the question really goes at, what should healthcare workers be doing in their hospitals and asserting in terms of their own rights to keep themselves safe and protected, given just the variety of responses from managers and supervisors.
Good. So Donna, I'm going to ask you to take a crack at that, and then hear from Gisela as well.
So I've heard this before. I've heard this question from someone else today, and there seems to be this, as healthcare workers, we've been trained in recognizing when we should wear personal protective equipment, and then some of these managers have not been trained when they should wear it. So there seems to be a conflict. I would say that we should keep in mind that there are different levels of these masks. So there's isolation mask, there's a surgical mask, there's a N95 mask, there's a PAPR, and there's different levels. And refer back to if it's 3 to 6 feet and it's droplet and low exposure, and it gets very complicated in that. But I think what people are really fearful of is if they're in close contact, individual look at your particular situation. And then you always have the ability to, if you're absolutely concerned, call the safety stop, call it out and say, I'm not comfortable doing that until I have the proper equipment. Reach out to the DONP, reach out to your, to who's ever in your local facility. I would recommend people get to know who those people are right now, because this is very real, and it might get a little more real as we go forward, because unfortunately we are facing a shortage on these masks. So I guess to summarize it, I would say first, be comfortable yourself with what level of PPE do I need to wear? Have those conversations, get it certain in yourself, and then adhere to that. Make sure that others around you are adhering to that. I walked through the hospital today and I saw some people that were just wearing N95 masks around their neck, and they didn't really need to be doing that. So we should make sure that we're all wearing the appropriate level of mask, and assert for yourself. And reach out. I did hear that there's some of the stuff in the works right now is working with outside companies to get masks that are in different markets. Like maybe we'll be doing, construction workers wear masks. So there's a lot of different masks out there. We may be bringing those in, nothing coming in yet, but you may be seeing that's going to come out in the future.
Great.
So, then we're going to also be the other, sorry, my phone's going off.
So
the other thing, if I just, let me just finish.
Sure.
We'll also start reusing masks. So there's also, you're going to see that. So we'll have extended wear masks. We'll be reusing masks. We'll be cohorting patients so that you can go from one patient to the next wearing the same mask. So I totally get that this is a scary topic. So get educated yourself, reach out and know who to go to.
Great. So Gisela, thoughts, and then from Jessica as well.
Yeah, well, I'm pretty much second what Donna is saying. Said one of the best way to do is that everybody educates themselves on what each mask can do and why and when do you need a mask. Much more important for somebody in respiratory who's given a breathing treatment to have a mask, while if you transport somebody through the hall, if you short a mask, that might be on the lower level of the spectrum of having a mask. So, but there's such a anxiety about, oh, I need a mask, that people overlook. And just like Donna was saying, you see people with the mask wrapped around or not in their face, and that could be the mask somebody else needs when they really need it. So I think there needs to be the continuous thoughts that we will be running out of that stuff, and we need to make sure that we use it wisely and make sure that everybody educates themselves and educates their managers, because oftentimes they really don't know, unfortunately.
Jessica?
So I think to answer the second part of the question, I agree with what they said, but to answer the second part of the question, why aren't we able to bring our own masks? We got to be very careful, because there are certain masks that we are fitted for. Some of the things that are out on the market, and N95s that are out at the, Home Depot and other places like that, may not be medical grade. So we need to be careful with that. So before we bring any type of supplies from home, whether it is a bleach wipe because we don't have enough in the facility, or especially protective devices like a mask or goggles, we got to make sure that they're the appropriate thing, because you may be exposing yourself trying to protect yourself. Another thing is, if we are demanding at every facility that we have training on what is the proper PPE to wear for each classification, for each situation that we're under, we need to make sure that that is happening. If that is not happening, reach out to your union leaders so that we can address this. We're having weekly meetings with leadership from the facilities. We're having bi-weekly meetings with like regional level and other forums like that, come to the
question. And one of the things I want to stress for everybody watching is that we really are constructing information and feedback loops at each of our employers, from the largest one, being Kaiser, down to small independent hospitals. At Kaiser, for instance, as both Donna and Jessica said, we have a statewide meeting with top officials twice a week. We're having information and feedback loops that are happening on a regional and a facility level. And we need to be constantly vigilant. There's no question there's inconsistency. It's for all kinds of different reasons, and it's not just at Kaiser, it's at other places as well. And I think we have to recognize that this is going to go on for several months, and we have to also just be constantly getting better and making sure that we're doing everything within our control to bring these issues of inconsistency and problems to the attention of decision makers at the facility level, at the regional level, and at the statewide level, depending on where you work. So I want to stress that. As happens every week, the time goes very quickly, and we're always committed to keeping these to 1 hour. And unfortunately, we've gone a little bit over. Final announcement I want to make is that we're going to work again to put the best information up on the website. We'll be working quickly to get up-to-date FAQs on the website, www.seiu-UHW.org. Please go there. You can leave questions and comments and all of that, and we'll be as responsive as we possibly can. I want to thank Donna and Gisela and Jessica for taking time to do this tonight. And we'll do this again 1 week from tonight, 7 o'clock. Please be in touch. Let's communicate. Let's look out for each other, and let's be safe. So thank you, everybody, and we'll be back in a week. Good night.
Good night.
good night.
Night.